Okay, so my name's Simon Williams. I'm a consultant urologist in Derby, and I'm going to talk about endometriosis and the urinary tract, or how can a urologist help? So we can help in two ways. Firstly, in the diagnosis of these women, and also in the treatment. So the treatment is either to help with the excision of the endometriosis, but perhaps just as importantly, to prevent or manage iatrogenic injuries. When I say prevention, putting stents in, that kind of thing, even though our gynecologists here are pretty slick at putting stents in themselves, so I no longer get called quite so much for that. So I'm not going to talk very much about asymptomatic ladies, because that's already been covered, but it's quite sad when we see a kidney that's dead because of the results of endometriosis. So what I was going to concentrate on is really the differential diagnosis of these ladies. We've spoken about endometriosis, but when these women are referred, they've got pelvic pain. And who they come to, whether they come to a urologist, a gynecologist, or a gastroenterology, is sometimes appears to be a little bit random. So what are the diagnoses, which has already been covered? Women with pelvic pain, it could be endometriosis, it could be a painful bladder, and it could be irritable bowel. And it's perhaps better to label these until you've got a definite diagnosis. It's probably better to say these women have got chronic pelvic pain. As soon as you start giving someone a label, it's very easy to become blinkered and not think about the differential diagnosis. One of the things that I've seen previously is a woman comes to my clinic, and she's got pelvic pain, and she's got irregular heavy periods and some dyspareunia. So I send her off to the gynecologists. She get in the gynecology clinic. She clearly has also got some bowel symptoms. So she then gets referred to gastroenterology. And when she gets to gastroenterology, she's talking about a bladder and gets referred back to me. And it's 2 years later, and no one's actually done anything for this poor woman. So who should I be seeing? It's tricky because these women often will have bladder symptoms. The pain from when we see ladies with painful bladder, it often worsens at some time of their menstrual cycle. And so the fact that it's cyclical pain doesn't necessarily mean that it's gynecological. The key thing, to my mind, is asking women, if they've got frequency, it's saying what happens if you don't go. Because if they don't go and they wet themselves, that is an overactive bladder. But if they don't go, if they're emptying their bladder because of pain, that, to my mind, is the hallmark of a painful bladder. I think the one thing I would like you all to take home is ask these women about ketamine use. Ketamine bladder is an awful condition. We seem to see a lot of it about 10 years ago, and I haven't seen anyone for about 10 years, and now I've got another flurry coming through. So I don't know whether something to do with COVID, people went back to using a lot of ketamine in the community, but we're seeing a lot of men and women with ketamine bladders again. So what do we do for painful bladders? The first thing is ask ladies to keep a diary. So I want to know when their symptoms are good, when they're bad, and what they've eaten and had and drunk in the previous 24 hours. Lots of these ladies can find triggers for their painful bladders. simple analgesia, non-steroidals, that sort of thing, as we've heard before. Pentosan polysulfate, which his trade name is Elmiron, can have fantastic effects for painful bladders. Nortriptyline as its pain with its pain modulating effects, and then slightly oddly, cimetidine, and it's got to be cimetidine, not ranitidine. The trouble with cimetidine is it's quite difficult to get a hold of now, which potentially improves the effect if it's a placebo effect. A drug that's difficult to get used to, get hold of, seems to work better. And then hydroxyzine, a sedating antihistamine. So bladder installations, things to replace the gag layer in the bladder. We tend to examine these ladies under an anaesthetic and stretch their bladder, which will make their bladder pain get worse for 24, 48 hours. But it does have, for some women, they find it very helpful for 6 months or so. You can refer them for implantation of neurostimulators. Some people have used Botox, and the ultimate treatment is to divert their urine and even to remove their bladder. So my take-home message, we've already heard: image, if you're worried, image the bladders. Don't refer everyone who has got a little bit of frequency, but if its bladder is their predominant symptom, by all means send them along, and make sure you ask whether they have been a user of ketamine, either presently or in the past. Thank you.
Thank you.
Simon.
Thank you so much,
Sybil.
Simon. No, not at all. Does anybody have any questions, ladies and gentlemen? I think there is a question by Dr. Aisha Ajmi. Mr. Abdul, should we?
Yes,
Is that all right?
to turn your microphone on and ask your question. I think Aisha's question is: painful bladder the same as interstitial cystitis?
She's yeah.
Yes.
Okay.
That's the question, actually. Yeah. So I've heard of interstitial cystitis being a cause of chronic pelvic pain. So painful bladder is, are we talking about the same thing?
So I would regard interstitial cystitis as the end stage. To me, interstitial cystitis has got some classical findings: Hunner's ulcers, glomerulization when you decompress the bladder. Lots of women have not got that. So interstitial cystitis is a subset of painful bladder.
Okay, thank you.
I'll just make a quick comment. Thank you both for interesting lecture. Thanks, Simon, for your contribution, really valued, and Sobel for presenting the 10 cases. I just wanted two quick things, one for Sobel and one for Simon. Firstly, the purpose of the presentation of the 10 cases is to just raise awareness, although it is a rare thing, but it's life. You lose a kidney, and sometimes silently, and sometimes iatrogenic, I have to say. So just firstly being aware. Secondly, you mentioned that screening. Screening is actually very simple. And if any lady is suspected to have significant endo, yes, intermediate level endo, some uterosacral, from clinical examination, for MRI, from laparoscopy, I think we need to just do a ureteric scan, renal scan. It's while all of them have a scan, all the patients coming with chronic pelvic pain, they go and have a scan. It doesn't take the sonographer or anything to just do a quick renal scan to check if the ureter is dilated or not. So that screening is so easy. Yes, we may not, it's not very common, but it would be serious. The second question to Simon is, this bladder pain and whether it is interstitial cystitis or not. Is there any rule for cystoscopy and bladder distension?
Yeah, I mean, the thing about the slide at the beginning about the who they get referred to, I think it's in medicine, you do the test that you're used to doing. So the same lady coming to see me will get a cystoscopy, and if it's for pain, I would do that under general anaesthetic. If she comes to see you, you'll laparoscope her and do an MR, and she might have identical symptoms. So yes, I pretty much all women I see with painful bladders, I will cystoscope under general anaesthetic to look for findings of interstitial cystitis, but also as a therapeutic thing. It does settle some of them.
So
I suppose the question is, should all patients who are having a laparoscopy for pelvic pain and some bladder symptoms have a cystoscopy at the same time, Simon? Because ultimately, I mean, MRI is not going to pick up your subtle endometriosis, and laparoscopy, or isn't going to pick that up. What are your thoughts? I'll put that out there just as because obviously if you're going around in circles.
I don't do the cystoscopy unless I need to obviously put a stent or something. But I've had a couple of patients coming to me already on waiting list to be scoped by someone else and cystoscoped at the same time because of the bladder pain. So I question the value of, and this is why I'm asking the question: is it valuable to cystoscope them and distend the bladder? Because my eye is looking at the bladder is not the same, obviously, as.
Yeah. So to my knowledge, there's never been a randomized controlled trial with a sham operation versus a cystoscopy. Certainly, there are some women who get a good response. Now, if you just gave them an anaesthetic, would they get the same response? Is it placebo? Is it the fact that, oh, they've taken my symptoms so seriously, they've actually given me an anaesthetic? I don't know. I mean, pain is I'm not a pain expert.
I think pain in itself is a very complex modality to manage, and I think again you have to, and correct me if I'm wrong. I mean, I'm still very junior and in learning, but I think we just have to approach a robust, holistic view and just make sure that if patients have got risk factors and if strong degree of clinical suspicion, then yes. I think we could argue that we would need to do a cystoscopy, Prof. Do you agree? Or if
is this not crying out if it's not done routinely? If you've got a centre that's got stage, advanced endometriosis being referred anyway.
Yeah.
If you're going to do a laparoscopy, to me, would it not warrant just doing a cystoscopy just to get a baseline and a study looking at what the prevalence is and undiagnosed? Until you look, you won't see.
Yeah. No, I think the one could argue that I mean, patients who are in that much pain, chronic pelvic pain, they probably won't pay that much attention to urinary symptoms. They might give you a different set of symptoms. They might not complain of urinary symptoms. But then again, if you're doing a cystoscopy, and if you damage anything, if you cause harm.
Simon, what are your thoughts? I mean, if just I'm playing devil's advocate here because ultimately, if we've got no studies that show a true prevalence, and the best way to look at it is by cystoscopy potentially, not necessarily imaging.
Just do one in.
Is it worth doing a prospective study looking at the prevalence of bladder endometriosis by doing cystoscopies on these women who are having laparoscopies?
No.
And we can actually just say, or is there anything out there, Saad? I don't know.
No. We don't do cystoscopy to diagnose.
I know you don't do them at the moment, but I'm saying,
No. I'm just talking about this specific point about endometriosis. This is out of the question. We're not looking for endo because we will know beforehand if we're suspecting bladder endo or not. That's a different scenario. We are talking here about the possibility of this bladder pain syndrome. The question is clear. Is it beneficial to scope them, cystoscope them, and see what the bladder looks from inside and whether distension helps? And I think Simon has answered it very quickly, very well. So I guess it's a case of if every patient will be assessed, as Subul said, its own merit, and see if there's a major bladder contribution to the pain. Maybe I usually write to Simon, ask for advice, and then if he advises for cystoscopy, I can do that, or he can do it as if he joins us in theatre.
Yeah, I mean the other thing is if you have a woman who I mean, my understanding of endometriosis is it's relatively common to be found asymptomatically. So women with bladder pain, some of them will have spots of endometriosis if you laparoscope them. So if you laparoscope them, treat their endometriosis and scope them and distend their bladder, and their symptoms get better, is it the fact you've treated their asymptomatic endometriosis, or is it because you've stretched their bladder and treated their painful bladder, or is it their endometriosis that was causing the pain?
One of the things we find in endometriosis patients, very commonly, they have bowel symptoms, mainly pain.
Yes.
And my theory is that when we scope people with endo, even though they have splashes of endo here and there, but the whole pelvic environment has a lot of cytotoxins and inflammation, that I guess, I'm guessing that it has an impact. And sometimes these patients will actually get better. Their bowel and their bladder, whether it is psychological, whether it's the direct impact of removing that inflammatory tissue, I don't know. But I think it's an uncertain area. Yeah.
I mean, I interestingly, when I see people with overactive bladders, it's almost all of them have bowel symptoms as well. So I don't think there is any such thing as an overactive bladder. I think it's a dysfunctional pelvis.
Yeah.
And if you ask people, men and women, with significant overactivity, they will always have some bowel symptoms as well. And it'll be interesting to ask Sarah, when she sees someone who's got a lot of bowel symptoms, how many of those have got bladder symptoms as well.
So
I
that
think
is, I mean,
Sarah's
there
coming
is,
in next.
yeah.
Sarah, do you want to come in there? Putting you on the spot, sorry. Sarah,
Hi.
do you want to turn your screen on, Sarah? Or camera?
1 second.
Simon, do you want to just ask your question again of Sarah? You said we were going to ask Sarah.
So Sarah, what the point I was making is, when I see men and women with a lot of bladder symptoms, they almost all have some bowel symptoms as well. And I wondered whether it's, if you see someone with irritable bowel, how many of them have got bladder symptoms as well?
Yeah, I agree. So I think a significant proportion of patients who've got bowel symptoms will also have bladder symptoms. And to be honest, I think that actually applies to the majority of them. And I suspect, again, it is probably due to the fact that there's just an inflammatory environment. And so all the pelvic organs are affected.
Again, data suggests that, I mean, I've just put that up also on my slide, that patients with rectosigmoid disease or deep infiltrating rectosigmoid disease have got a 22-fold increased risk of having, deep urinary tract involvement with endometriosis, ureteric, bladder. So I think that that is the evidence to support.
Interestingly, I have a joint case with Sarah. We very challenging one, who's had surgery for excision. She's got significant endo, not necessarily involving the bladder or the rectum, but wide pelvic side walls. I've done the excision, didn't do any work on the rectum, didn't do any work on the bladder, but she comes back with really serious blood. I've sent it to you, Simon, I'm not sure, with really serious, really severe bladder and bowel symptoms, and we don't know why she's having major functional, I think, problems. I think this is a very uncertain area, and pain and bladder and bowel symptoms are very complex. It's multifactorial. There's a lot of psychological element to it. There's the nerve networks in the pelvic area. I think is very complex as well.
Yeah, I agree with that. And actually, that's something I'll discuss in my presentation. I think the problem is there's a lot of risk to injuring the innervation of the bladder and the bowel during endometriosis surgery. So there are sort of schools of thought about ways to avoid doing this.
Yeah.